I'm talking about pelvic floor dysfunction and imaging, and my disclosures are that I've had some software support from both Philips and GE, and I've also done some lecturing. The objectives of this talk are to review the anatomy of the pelvic floor, to review the sonographic findings for fecal and urinary incontinence, and to demonstrate puborectalis avulsion and sphincter tears. Urinary incontinence, anal continence, and pelvic organ prolapse are all part of pelvic floor disorders. Any one or more pelvic floor disorders was found in 37% of community-dwelling women. When I read that, I wondered, what's a community-dwelling woman? Well, that is someone who is not in a nursing home. So people like you and me walking around. So in this study, there were 4,000 plus women from Kaiser who were from 25 to 84 years old, and they were just randomly identified by age, and 37% had one or more pelvic disorders. 15% were stress incontinence, 13% overactive bladder, 6% organ prolapse, and 25% had anal incontinence. So what are the causes of fecal incontinence? Well, muscle damage from childbirth is probably number one. It's possibly related to forceps being used at delivery and episiotomies being done at delivery. But not everything is related to childbirth. Some are hemorrhoidal surgeries, pelvic tumors, anal sex, nerve damage from childbirth again, from long-term constipation, stroke, nerve degeneration from diabetes, which we have a lot of today, multiple sclerosis, loss of storage capacity from radiation treatments and inflammatory bowel disease, diarrhea, and pelvic floor dysfunction, decreased squeeze pressure, impaired anal sensation, rectal prolapse, and rectoceles. How do we diagnose these things? Well, there are indices of different questionnaires, and probably the most popular one is called the FESI, which is the Fecal Incontinence Severity Index. And this little questionnaire has questions on the types of leakage, whether it's gas, mucus, liquid stool, or solid stool, and the frequency of how often these happen. Do they happen 1 to 3 times per month, 1 time a week, etc.? You get a score based on your answers, and if you're greater than 4, you're considered to have fecal incontinence. Now, what are the tests that we have available to diagnose these types of abnormalities? First, anal manometry is used, where they test the pressures of the rectum when you do these squeeze mechanisms. Anal rectal sonography using 2D, endoanal, and 3D. Defecography using barium studies. Proctosigmoidoscopy to look at the area, and anal electromyelography. What types of treatments do we have available? There's dietary changes, there's medications, there's bowel training, and then lastly, there's surgery. Well, this is an anatomical diagram of sort of like a cartoon of the muscles that you need to know about. First off, the symphysis pubis is a very important landmark for us in identifying this region. Then we have the urethra, then the vagina, then the rectum, and then the muscles. Now this is the puborectalis muscle here, but you can see there's a iliococcygeus, anterior sacrococcygeal ligament, and many people reference these as the levator ani. And so you'll find in the literature many different terms, but these muscles do come back here to the sacrum posteriorly. Now, how do we do these studies? We do them with a patient lying in the lithotomy position. If we have stirrups and we're in a lab where there are tables with stirrups, then we use stirrups. If there's no stirrups, then we let the legs fall against the bed rails that we keep up with a pillow against them, and then the legs falling across. There's 2 types of transducers that are being used. One is the 3D transvaginal probe, which is a 5 to 9 megahertz probe, with a condom, of course, and that gives you better resolution, but the 4 to 6 curvilinear transabdominal probe sitting on the perineum gives you a broader based window to the hiatus. The transducer is placed on the perineum near the introitus on the perineal body, and if you don't know where that is, you'll know in a few minutes. It's very important to use a light touch, as the transducer pressure thins out the external sphincter and can cause you to think that there's a defect when there isn't one. So in contrast to most of ultrasound where we push, in the pelvic floor, we want to lift up. The dynamic information is very important when you're doing pelvic floor work. We look at it both with resting and with squeeze, and most of our tears of the internal and external sphincter are much more obvious on our patients where we contract and bear down than when we have the resting state. We generally have the patient hold their breath. You would think that it's far enough away from the lungs that it wouldn't impact it, but image resolution is everything when you're trying to decide these. And some studies are being performed with 4D ultrasound in order to see the movement of the pelvic floor. So here's a diagram with the transducer sitting right on top of the introitus. We do put in manometry catheters for research purposes, but this won't be done on a routine basis. There's the window of what we're going to look at, and then we kick out a orthogonal planar image where we have 3 perpendicular planes looking at that. We also in our lab have looked at the pressures, but that's basically been done for the research purposes to understand what we're looking at. So here is the basic 3D multiplanar picture that we take. We start in the sagittal plane and acquire here with the anal canal and then the rectum coming down. And then we have the transverse image off to our right in box B with the puborectalis muscle there. And then we have our coronal picture through the anal canal. Now if we take a slice down here near the anal angle, we will get a nice picture of the puborectalis, this white sling, and then the internal anal sphincter is the black. And then on the lower part, we can see here that the perineal body sits right on top of the anal canal, and you can also see the puborectalis muscle and the internal sphincter. The rectum is down here. And there is, again, the perineal body right there. If we go more proximally in the anus, then you will see the black ring again is the internal sphincter and the white ring is the external sphincter. Now this is just another diagram of the same thing, the perineal body right up here, and here's our ring of our anal canal, and we did some measurements here just to see what normal measurements were. And once again, the black ring is the internal, the white ring is the external. I like this picture from Dr. Timur Trish's paper because it kind of has a nice picture of the anal canal right here and showing that if you are more distal here in the anal canal, then it looks more like this, and if you're more proximal there near the angle, then it looks more like this. The MRI is also helpful. This was a 21-year-old. That was having probably asymptomatic, maybe it was a volunteer, I'm not sure, but notice how thin these muscles are that are drawn out here in this cartoon of the internal sphincter versus the puborectalis. And notice that the external sphincter has a little cup here that it comes around, and it's called the superficial part of the external sphincter that cups around there. But notice how thin these are. Now maybe part of that is because of the coils that are in here pressing everything out. But that's true for the endoanal ultrasound as well. That's one of the reasons we really like 3D ultrasound is we don't have to put anything inside the rectum. Here we have a beautiful picture from Timur Trish, who coined this the mucosal star in the middle of the anal canal, and I really like that, the mucosal star, because it ends up being quite helpful to us when we have abnormalities. So here's an abnormal star, and notice right here that you can see that being pulled up to the anterior part, which is where the tear is. And notice this normal for comparison down here in the bottom right corner, how smooth and round it is in comparison to how this is moving up in the star in this patient with a 4th degree tear. Now we did originally our research looking at using Photoshop to help us move along, and we found the puborectalis muscle and watched it in the internal sphincter and the external and saw how it changed over distance as it went towards the anal verge. But then our companies helped us develop these multi-slice or parallel slice techniques that you can see that the external sphincter is coming in right here. There it is, the external, and now the internal begins to come in right in here. And as you go along, you see here's some more of that external right there. And then once again, we're seeing both. Now at the anal verge, you can see that you have more of the external sphincter, and then at the midpoint you have the internal and the external, and then as we get towards the anal rectal junction we have just a little tiny bit of the external and much more of the internal. So that's the normal progression. Now when we started using thick slice, we found that we could actually see these sphincters better, and so whether you use a small narrow volume or thick slice, whatever VCI, whatever the company is using that you're using, you will get better pictures. Now the measurement of that thick slice I think is not very reproducible from one piece of equipment to another, and on one equipment we would use a thick slice that was like 10 and another we'd use it as 1 millimeter, and they looked very similar to us. So I'm not sure how the thick slices are working for the companies, but I don't think that they're exactly what they say. Here you can see disruption of that mucosal star going into that internal sphincter right now and probably going into the external as well. And you can see that on this rendered picture as well as right here where that is.